All right, everybody, and welcome back to the Provocateurs. This is our second episode. Today we're going to have a national panel with us. Well, the first thing we're going to talk about, there was a recent article that came out in Medscape. So essentially, Medscape had this article that came out which talked about doctors' 10 biggest mistakes when using EHRs. One of them was doctors enter too much information in the EHR. What do you think about that, Renee?
Well, first, let me just say that I think part of the problem is that EHRs are made by software companies who actually have no clinical or healthcare background. So by virtue of them not having the experience of or knowledge actually of healthcare and how it is practiced, I think that part of the problem is that the EHR facilitates doctors putting in way too much information. I just think that software companies need to kind of stay in their lane when it comes to EHRs. And I think what happens is doctors then take on the brunt of the responsibility of the inefficiencies of the EHRs, when in reality it really is probably the problem of the software companies.
Well, I agree with Dr. Volny, but I also agree with some of the pieces in the article about that physicians really need to take a closer look into some of the EHRs that are being bought, that are being utilized. But case in point, so I'm an employee physician, so I don't have a say-so necessarily in the type of EHR that my hospital uses. But also, the state of Ohio, all of the children's hospitals came together, where the administration have come together to determine which EHR will be used for all of the children's hospital, to kind of make it a universal type of approach, so that regardless of wherever the physician or the child, whomever, go to different hospitals, they can be under the same type of system. That's fine in the case of if the EHR is working well, but if there's any changes that need to be made, it's very difficult. And actually, in part of my role is doing administrative work for a specific clinic or type of specialty clinics. I have to make changes to some of our some of the notes and some of the preset notes. It's very difficult. It takes a long time. It takes months to be able to do it, and it's very inefficient for the providers. It's inefficient for the patients. So I mean, I definitely think there needs to be some type of improvement in terms of the utilization of EHRs.
All right, Todd, what do you think about all the documentation? Do doctors put too much in the notes, too little?
I do concur with both the doctors here that electronic medical records are incredibly inefficient. There's way too much that you have to put in there. And just the fact that the companies aren't employing medical professionals to try and design these systems does not facilitate a good workflow in a hospital. And so it just means you have to go out on a limb and put everything and anything you can think of in there.
All right, and then a lot of folks are using these macros or shortcuts and cutting and pasting things in there. And that obviously opens up to its own issues.
When you use an EHR, one of the things that you try to do is actually to increase your efficiency. The problem is that the EHR itself can actually slow you down. So when you do get slowed down, you try to find ways to essentially continue to have a level of efficiency, and some of that may be templating, cutting and pasting, and inputting information in such a way that you would not have put it into a written chart. So that actually can cause some problems, because you then tend to potentially overlook some of that information that was included either in the cut and paste or in the template, because again, it is a lot of information. So, you know, I think we are on a slippery slope here to putting liability on physicians that we otherwise would not have had if EHRs weren't necessarily either available or set up in the way that they currently are. I think we need to be very, very careful about that.
Okay, Tyree, do you ever cut and paste when you're doing your notes?
I do it quite frequently. I cannot lie. I mean, it's based off the fact of I have to produce. I have to be able to see a large number of patients in a short amount of time. And when you use an EHR, it, as we've all said, it can be very timely. It can be a very task burden type of process. The one thing that I will mention is that with some of the EHRs, the ability to be able to auto-populate some of the fields have been a very slippery slope and dangerous type of dangerous way for us to be able to do some fraudulent things, or not even fraudulent, but necessarily mistakes. So case in point, if you click just one simple button, it'll auto-populate to have a normal exam. You saw about 30 patients in a full day. You forgot to document that one of those patients may have had a heart murmur. And so it's kind of hard to go back to remember, like, oh, which patient was it that had the heart murmur? And then when you look back, you've clicked that one button to auto-populate, and everything is coming back as it's a normal exam. So I think that that's one of the things that I find, especially with shortcuts and cut and paste, that can be problematic.
Most of the nurses I know hate the electronic documentation, especially when I was at one hospital when we transitioned from paper to electronic, because it just made their documentation take so much longer. What are your thoughts?
As far as the EHR that we use at our facility, there are different venues for different sections of the hospital, and they don't talk to each other. So one nurse in an ER can do one thing, and no nurse in any or physician in any other part of that facility will ever see that. So the communication just needs to be there for that kind of thing.
All right. Well, let's shift gears a little bit. We're going to talk about how much money people in healthcare actually make. There's been a lot of information out lately. Medicare did this thing where they did a data dump saying that how much your individual doctor makes, and we can look up stuff. I looked up my numbers, which was interesting, and I also looked up Tyree's and Renee's as well, which is fun to look up your friends and see how much money they make. All right. So New York Times had this article out called Medicare's top earners are not the MDs, and the focus of it really was about how much hospital administrators make in terms of the people that are the CEOs of the hospitals, the other administrators, vice president of this, vice president of that. Renee, you're the business person. You have an MBA.
Yes.
So why do all these administrators make so much money relative to the doctors?
Well, apparently they have a good gig going. That's pretty much, I think that's pretty much, the bottom line. No pun intended. But, I will tell you that at a previous hospital in which I worked, a small critical access hospital, which had 25 beds, literally 25 beds in a small rural community of about maybe 10 to 15,000 people. The CEO there was making $7.2 million, which I think is just excessive, absolutely excessive.
Yeah, it's kind of crazy.
Yeah, considering the amount of work that doctors and nurses and other staff members put in, I cannot justify in my mind why a hospital administrator makes as much money as he or she does. And I will tell you, as a compliment, if you will, to that particular article, there was another article, can't remember in which publication I saw it, but about 2/3 of American hospital CEOs have no healthcare or medical background. That is alarming, absolutely alarming, because then what you run into is that the quality of healthcare is being determined potentially by people who absolutely have no understanding of science, the human body, or medicine as an industry, or at least as a practice. But they do understand the business of medicine, and the reality is that sick people make a lot of money, and they're finding ways to milk that, and I think they're doing a pretty good job.
Yeah, the numbers that the New York Times article put out was that the average CEO pay was about $584,000. Average hospital administrator $237,000. The general MD, probably like an internist, whether or not that includes like pediatrics and other primary care specialties, is around like $185,000 a year. And then who really gets the short end of the stick are, they had EMTs in there, which made about $27,000, and nurses, which made $62,000 a year on average. You know, so it's like 10% of what your hospital administrator makes. So Todd, how does that make you feel?
Well, I can let you know that the nurses are aware of all this, and it does not sit well with any of us. The fact that we are the ones that go out, physicians, EMTs, nurses, and we're the ones providing the services directly to the patients, and yet your average hospital administrator is making over $500,000. Like Renee said, it's a good gig. You're on the top. It's not just, I think it's a systemic problem. It's not just healthcare. It's you're on the top. You want a larger slice of the pie.
Some of the comments I think about, just case in point, in my background, I was a pharmacy technician in the hospital before I went to medical school. And as a pharmacy technician, one of the things I realized was I could not, when the patient's being billed, there's not a specific way to bill for my role. So I can appreciate in the sense of when you're looking at the total amount that is being charged for a patient's visit, whether it's to the hospital, to a clinic, whatever, that a certain part of that has to go to overhead, just to keep the lights on in the building. Other part has to go to our support staff, our allied health folks. However, when you're thinking about the administrators and the type of roles that they are playing in terms of the overall care of that patient, and then you look at the percentage of how much of that patient visit is going towards their compensation, I mean, it's appalling. And that's one of the things that, obviously we need administrators for certain things, but at the same time being able to make sure that the one who is actually getting the short end of the stick in this situation is the patient. Because the patient is not being able to, or going into debt over things that they necessarily may not need to go into debt over, which is higher compensation for administrators.
Gotcha. All right. Well, we're going to take a quick commercial break. It's going to be real quick because we have no sponsors yet, but if you guys would like to sponsor, you like what you see on this show, please send us an email. And we will. And if you follow us on the Policy Prescriptions blog, you'll know how to get in touch with us. We'd be happy to have your sponsorship to make this better and to keep doing this regularly. All right, and now back to our regularly scheduled program. Okay, the last thing I want to talk to you guys about was this article that came out that said nurses are not doctors. I know you've all looked at it and read it, and it was essentially talking about nurse practitioners in New York City recently allowed nurse practitioners to practice without the supervision of a physician, and they join about 16 other states and the District of Columbia in doing this. And part of the reason behind it, there's been a large push for this in terms of increasing nurse practitioner autonomy, practicing at the top of their license to help out with primary care and other things like underserved medicine. Let's start with Renee again. Your thoughts on nurse practitioners and their role in medicine?
Well, I think that definitely a certain level of providers in medicine. Certainly, nurse practitioners do complement the practice of medicine, particularly in areas in which there are shortage of physicians. Now, I will tell you that in my mind anyway, there is a precedence for this. I actually trained in New Jersey, and in one of the hospitals in which I trained, we did have a nurse practitioner, and she saw exclusively pretty much obstetrical patients. But she saw obstetrical patients who actually had normal pregnancy. So anyone who became a high-risk patient was then, transferred over, if you will, or seen by the resident service and or the attending physician who was in the clinic. So for me, I think that there is a role for nurse practitioners to be able to see patients, especially patients who are not necessarily very complicated, to help lighten the load potentially for physicians who are dealing with patients who are definitely much more complicated. So I actually tend to agree that there is a role. I think that role needs to be very well defined so that they don't necessarily incur liability that they don't have to or should not incur.
Okay, so Renee's sort of saying there's a role for nurse practitioners, but it needs to be kind of well-defined and sort of narrow in scope. Todd, what are your thoughts?
Well, I think that nurse practitioners, especially in the primary care setting, have shown that through the research that they can practice as efficiently as a primary care provider can. Like Renee's saying, I think that they need to be able to move a patient that is a lot more complicated onto a physician. Some things that they're just way out of their scope of practice to even to practice on. But with the physician shortage that is coming up, something like 100,000 doctors in the next 10 years, and a lot of those are going to be primary care providers. I think nurse practitioners increasing their role in primary care is going to be very, very important, and it's something that we're definitely going to have to look into.
All right, Tyree, this kind of hits closer to home to you, since you are a primary care provider. So what are your thoughts whether, NPs should be out there working completely on their own, no supervision whatsoever by doctors?
So I'm happy that you mentioned all that. Also similar to Dr. Volny, with my training as well, I worked a lot with nurse practitioners, especially in some of the subspecialty areas. So like the neonatology, so like NICU, as well as with the pediatric intensive care unit. Nurse practitioners served a great role in a complementary realm in terms of with physicians. In terms of practicing by themselves, I think that's where time's going to tell. And the reason why I say that is because of the fact that when we talk about research, most research is unequivocal. It doesn't really show us whether or not that nurse practitioners can operate in the role of a primary care provider, and there are not to be any specifics that can be resulted from the fact of them practicing without a physician collaborator. I think the argument can go around and around, back and forth, and eventually what's going to have to happen is we will have to let time tell. Allow these states, and as well as the District of Columbia, to be able to, when they allow those nurse practitioners to be able to practice on their own, unfortunately see if there will be some adverse effects or adverse outcomes of that. Because of the fact that if we continue to keep going on with research, there's always something that says, yes, this is fine, no, this is not okay. The one thing that I will say, though, is that the Institute of Medicine, when they put out their recommendations for advanced practice in nursing, one of their recommendations was the fact that eventually nurse practitioners or advanced nurses will have to go on to become doctors or DNPs, have their doctorate of nursing, and then their recommendation was to additionally go through additional year or so of training in a specific area in order to be nurse practitioners. When you look at that, and by the time 2020 is when they are stating that that should occur, or start to have in place. When you look at that type of timeline of training, it's very similar to physicians, the way that we train. We have our doctorates, and then additional to that, we go through and do additional training. So between 3 to 7 more years of training, depending on your specialty. So it sounds almost like that they are leaning towards the way of what a physician is. What would be the difference of, instead of the nurse practitioner going through nurse practitioner training, to go through medical school as well?
I think that's one of the big issues and the big differences that a lot of physicians, especially with organized medicine, have, especially in places where nurse practitioner role is more restrictive, is what you alluded to, Tyree, with the fact that nurse practitioner training, if you get your MP degree, then you go ahead and start practicing independently the next day. People are worried about that, whereas as a physician, you have to at least practice. You can't even get a license without practicing under supervision for a year in most places, and you can't really become like board certified unless you do a residency, which at minimum is going to be 3 years most places. Todd, you got any thoughts on sort of that nurse practitioner internship almost, or nurse practitioner residency?
We'll say this, that there are a lot more programs going out for advanced certificates, so it gives you about anywhere between 600 or 1,000 extra hours before you graduate in a specific area, emergency medicine or critical care. beyond that, a residency program is not for nurse practitioners. Is not something that is of wide use, although I could see it coming into practice more in the future.
All right, Renee, any comments from you?
I would say that I think it's something that definitely should be taken into consideration, that there is some sort of postgraduate training for nurse practitioners, especially if we are saying that they are going to be operating independently of a physician. Again, I think that the right now the timeline of going to school, completing your education, but not necessarily going into additional training can be a little bit problematic. And I think that if nurse practitioners are going to take on the liability of practicing on their own, then one of the things that they might want to do as a protective factor, even to their own licenses and practice, is actually to practice under the supervision of either another nurse practitioner, or train, I should say, under the supervision of another nurse practitioner and or physician before they go out on their own.
The one thing I was going to say about this as well is if you look at the history of nurse practitioners, how the profession came to be, it was for those nurses who were in the field for 15, 20 some odd years, who those nurses, when they became out to be nurse practitioners, I mean, they very well were right alongside with a physician that was just coming out into practice who went through that training, versus now the way that nurse practitioners are coming out into training, as Dr. Volny said, is they don't have that additional training. I mean, you can be a nurse practitioner without even being practicing nurse before you even went into the graduate program. You can just do continuous straight through program from the time that you are entering into college as your freshman year to the time you leave out in 6 years. That's where I think the problem lies. Not for those nurses or those nurse practitioners that were training in a field of nurse or were practicing in the field of nursing for an extended amount of time before they went on to become nurse practitioners.
All right, y'all. Thanks a lot. This has been a great conversation. Thank you for watching the Provocateurs. We'll be back hopefully in a couple weeks next month with another episode. In the meantime, make sure to check out our website, www.policyrx.org. You can follow us as well on Twitter @PolicyRx or on Facebook. And a bunch of us also have our own Twitter accounts. You can follow them as well. And we'll see you next time.